And I think it's me to start with. So, hello everyone, and thanks for joining our seminar today. So, I'm Caroline Sanders. I'm Professor of Medical Sociology at University of Manchester, and I'm presenting with my colleagues, Dr. Josh Behan-Devlin, who is Research Fellow for this project, and Dr. Karen Staniland, who is our lead for public and patient involvement and also former lecturer in nursing. So I'll hand over for them to introduce themselves shortly. So today, as Sabine has said, we're talking about our qualitative research to explore barriers to digital inclusion for remote monitoring of rheumatoid arthritis. And this is in the context of this multi-center randomised controlled trial. And whilst focused on rheumatoid arthritis, we think there's inevitably learning relevant to digital inclusion beyond this specific focus on RA. So just presentation outline for the seminar. So I'm starting off in presenting some background, and Karen will talk about PPI, and Josh will present some of the work we've done and some of the implications, and we can open up for discussion questions at the end. Okay, so first of all, just some context to the study. So this work is being conducted in the context of the wider research programme designed to enable and evaluate transformation of outpatient consultations by integrating regular symptom tracking into routine care, as Sabine said, the so-called Remora 2 programme. There's a really large team involved, and only some of the names are here in terms of the leads and co-investigators. So it's led by Professor Sabine van der Veer and Professor Will Dixon, and some of the team are listed there as well. So just a little bit about the Remora app. So this is designed to tackle the problem of infrequent outpatient review, where specialists rely on patients being able to recall and summarise how they've been since their last appointment. And this inevitably has many implications for patients and clinicians in terms of making the most of those clinical appointments and the best decisions for clinical management based on personal experience and needs. So the app enables patient-reported symptom data to be collected routinely and integrated into the electronic health record, and enables the use of data for clinical care and decision-making, as well as supporting self-management, and also provides a potential data resource for research to improve treatment and services as well. So our next slide, this basically just shows some images from the app that collects responses to questions, some of which are daily, as you can see on the left-hand side, some weekly and some monthly. So this just gives you an idea of what the app looks like. And also this slide shows the clinician-facing dashboard. So the idea is that the graph tracks symptom changes over time, and flares are highlighted in this slide. You can see that by the red dots on the graph. Okay, so I thought I'd also just say a little bit of the context in terms of the work before the main this period of Remora 2 and the trial. So we have done previous qualitative research, and we're building on that in order to look on more specifically at inequalities and digital inclusion. So in the first proof of concept study, we did do some qualitative research and that entailed qualitative interviews and some observations focused on 20 patients at all stages. It was mostly women, white British, and a broad age group, as you can see here. So basically, we had a lot of positive feedback from patients who participated in the pilot study and also the PPI group. Many comments indicated that it was easy to use, and there was a high degree of engagement. Patients thought the graphs were valuable in visualizing how symptoms changed over time and capturing those changes that might otherwise be missed. And the data was in turn considered informative for discussions within the context of the clinical consultations that were observed. And you can see one of the papers that was studied was published from that work. And there was also a further paper by Louise Lafferty, Sabine, Dawn and others who led some of that, delving more deeply and looking at the timing of discussions around data in relation to decision making. So we already had these valuable insights, but obviously some limitations to that initial pilot work. It was a small sample in one setting, and we recognised the need to consider some of the issues around digital inclusion, much of which was also highlighted by the PPI group. And so within the context of the trial, there are multiple work streams, one of which is the digital inclusion work stream, aiming to understand barriers to digital inclusion and to co-produce materials and methods to support digital inclusion. So here we're focusing in the rest of the presentation, we'll talk about PPIE and then some of the qualitative interviews that have been done with people who declined to take part in the trial to look at some of these barriers, and also people who originally agreed but didn't actually register and start tracking symptoms. So I will now pass over to Josh, who's going to take over and say a bit more about what we've done within the current work. Thanks,
Great.
Josh.
Thanks, Caroline. So my name is Josh Behan-Devlin. So I'm Research Associate for Digital Inclusion on the REMORA-2 study. I'm going to talk a little bit about the link between remote monitoring and digital health inequity and how we've focused on that in the REMORA-2 study. And then I'll hand over to Karen, who'll talk about the PPIE involvement on REMORA. And then I'll talk a bit more about in-depth about the findings that we've found through our digital inclusion interviews. So Caroline's highlighted really nicely the kind of the opportunity and the promise that is offered by remote monitoring in terms of improving patient care. And this is kind of recognised in NHS policy where remote monitoring is seen as a key way of transforming outpatient care for long-term conditions. However, there are potential health equity impacts related to this. So we have evidence that patient groups who already experience health inequities tend to be further excluded by digitised health services. So this has particularly come into sharper focus since the COVID-19 pandemic and aspects of digitisation in primary care services. And digital inclusion is recognised as being important in health policy and obviously research as well. But sometimes there's perhaps a little bit of a tendency to focus quite a lot on kind of access and skills and focus on access and skills in quite a kind of narrow way, where the answers are seen to be kind of providing perhaps devices, connectivity, setting up skills workshops. And that perhaps overlooks the role that kind of confidence might play, and also the fact that some people just sort of choose to avoid taking more digital routes in healthcare services. And these things still might lead to forms of exclusion. And we've also seen from previous research, so going back a little while ago, thinking about kind of telehealth and telecare, there's a mutually influential relationship between technology development, its implementation, whether people adopt it, and the social context that technologies kind of enter into when they're introduced. So thinking about the whole system demonstrator program that Caroline worked on and wrote a kind of very good paper on about where patients chose not to adopt telehealth. So in this, some patients, it was found that their reasons were quite deeply entwined with their kind of self-concept around their illness. So saying things like, telehealth is for people who are more ill than me. Telehealth might stop me being active and getting out for appointments. So we know that the kind of social reasons and people's experience of identity are really closely linked to barriers to digital inclusion. Next slide, please, Caroline.
Okay.
And so all this has kind of underpinned our focus on REMORA, focusing on digital inclusion from a really early stage in REMORA-2 and also earlier iterations of the trial. So thinking about Remora specifically, there's several steps involved with download and setup, and this can pose some problems for some patient groups. So you can see here on the slide, these images are taken from are screenshotted from the patient guide that's sent to participants to support them to set up and download the app. So they download the app from the App Store, enter their Remora details, they're taken to the NHS login. So a number of steps that can be quite difficult for some patients. Remora has put lots of effort, the team's put lots of effort into offering onboarding and follow-up support. And we've got lots of evidence that during the trial, this has been effective in kind of making a difference of getting some people registered who might not otherwise have been registered after being allocated to the sort of intervention arm. But we still felt it's been important to speak to people who ultimately chose not to or couldn't use the Remora app. And that's what the interviews I'll talk about in a minute are related to. And there's also been actually several other areas of work implemented during Remora 2 that have been focused around digital inclusion and co-designed with our PPIE group. And Karen's going to now speak a little bit more about those. Next slide, please, Caroline. Thanks. I'll hand over to you, Karen.
So my name is Karen Staniland, and I'm a patient with rheumatoid arthritis. I've had it for about 12 years now, and I was recruited initially from a clinic appointment, going back now 10 years to the start of the Remora project, which we called Remora 1. And as Caroline said, it's evolved. There was Remora 1.5, and we're now in Remora 2. So patient involvement has been throughout the period of 10 years. The Remora 2 group was established in about 2021, around about the time of the pandemic. Initially, we had 5 members in the Remora 1.5, and it increased to about 11 members of patients with rheumatoid arthritis in the group. And we also appointed, I lead the Remora PPIE group with a co-chair, Paul, and we facilitate our own meetings now and chair our own meetings. Initially, we were facilitated by Caroline in a small basement room at Salford Royal Hospital. So it definitely has evolved since then. And I would say, next slide, please, Caroline. I would say that we are definitely involved and engaged with the Remora project. Josh showed some guides for patient downloading the app, and we were consulted and advised on the slides in the patient-facing information sheets, which took quite a lot of time, but all the group were able to give feedback, extensive feedback on what had been put together. In Remora 1.1, one of the main productions was a video for patients on how to examine their own joints. It arose at one of the meetings that although clinicians examined our own joints, very few of the group knew how to actually examine their own joints. So we put together a video with Charlotte, one of the consultants, MRI, of how to teach patients to examine their own joints. And that, at the moment, it's on YouTube, and it's had about 58,000 hits. So that was quite good. And as well as that, there are instructional videos for people who prefer seeing rather than reading of how to download the app and things like that. So we've co-produced the support materials in the information leaflets. And we also set up a patient peer helpline where if a patient wants to talk to another patient directly and not to a researcher, they can consult or they can email or phone the official helpline and be put through to a patient. As yet, although it's there, it's not very well used, but it's there if a patient wants it. And within the last year or so, we've started putting together a patient newsletter, which goes out directly to patients. So I think from that you can see that we are very engaged in this study. And one of the, Caroline mentioned work streams, and as a result of all this work, patients are now allocated to one of the work streams, and I'm allocated to the digital inclusion work stream, which is what this seminar is about. Okay, I hand over to you, Josh.
Great, thanks. So before I kind of get into the detail of the interviews we've conducted netted within the REMORA-2 trial, I'll just highlight that as part of the feasibility, a set of qualitative interviews were also done with people South Asian people who spoke English as not their first language, exploring their perspectives of remote monitoring. We're not going to cover that in the presentation today, but Caroline can touch on some of the findings related to that in the discussion if that's helpful, and we can also share to the publication from those interviews as well. But just thinking about the kind of nested interviews we've done as part of the REMORA-2 study. So we've conducted 32 semi-structured interviews with rheumatology patients. These participants, so they either declined to take part in the main study, so there were 17 interviews conducted with these participants, but they consented to be contacted for a follow-up interview, or they consented to the main study, were allocated to remote monitoring, but didn't register after 30 days. So the interviews really were focused around what their reasons were, what barriers they had faced, but kind of trying to contextualize these in their wider experience of living with rheumatoid arthritis, things to do with family support and offer to them, the wider patterns of using digital technology in their lives outside of a healthcare context. Most interviews were conducted by phone. Participants were given a choice of phone, Teams, or in person, and for most participants, phone felt quite comfortable and convenient. An analysis is focused really on trying to ground people's reasons for not taking part within this kind of broader context of their illness experience. Just also to note, all participants who took part in interviews also met the eligibility criteria for the main trial. So that meant they did have access to a mobile phone, either themselves or through a family member. And they also could read and understand English with support. So we do kind of recognize that captures people who are experiencing particular barriers and less so perhaps people who don't have access to these things. Okay, next slide, please, Caroline. Okay, great. So just talk a little bit about the findings. So in terms of who we interviewed, so as I said, we managed to interview 32 people. This was out of 88 eligible participants who were approached. So in total, there were 32 people who consented to be contacted, and of those we interviewed 17. And there was 57 people who were recruited, allocated, but didn't register to the Remora app, and we interviewed 15 of those people. In terms of demographics, the sample was slightly older, majority women, around a quarter were from different ethnic minority groups. And I've not got it on the slide, but also just over half were what we'd consider sort of low income, so under annual household income of under £20,000. Next slide, please. Thanks. So the four key themes I'm going to talk about today relate to the timing of approach that people were asked to take part and some issues around that. Remote monitoring posing as a constant reminder of illness for some patients, patient perceptions of Remora, and the relationship between digital confidence and patient social networks. Next slide. Okay, so the timing when patients were approached posed a barrier in a number of interviews. So patients in their interviews, when speaking about their experience of onset of symptoms of being diagnosed, spoke extensively about how this could be extremely difficult, extremely disruptive, and take time to kind of come to terms with the changes in their lifestyle. Typically, in the Remora trial, individuals were approached after clinic appointments to be before or after clinic appointments to be spoken to about the trial. And for some patients, this could present challenges. So, for the patient in the quote in the middle of the screen, this patient had just found out in their appointment that they had been diagnosed with rheumatoid arthritis after having experiencing symptoms for about 6 months before, and they were approached straight after. So I asked them, when asking them what were the main reasons why they didn't approach, they told me. So I think the main reason for me, after seeing my consultant, and my mind was so confused, I was overwhelmed with all the information that I was told. And your mind focuses on, well, it's incurable. And she did say that she was given written information to sort of take about the study to take away and digest. But this kind of just got lost amongst all the other leaflets she was given about a condition, about medication, and she just felt it wasn't the appropriate time to take part. This kind of idea of issues with the timing of approach didn't relate solely to kind of literally when people were approached in clinic, but also to the timing in people's lives if they were dealing with other changes or aspects of kind of upheaval in their life. So this second quote is from a participant she'd experienced a post-viral condition, and it was under investigation. She'd had to come off all her medications because of this. And so she told me, so yeah, too many appointments at the minute. My head just feels like it's too full of everything else to have yet another thing put on for. Yeah, I don't think I could cope with symptom tracking at the moment. What was really quite significant, though, about this theme and about these participants is both of these participants, when exploring their views of remote monitoring kind of more widely through the interview, in the interview we had a bit more space to kind of explain what it's about, what their views were of it. They did recognize the positives. They did say that there might be a time where they thought they could try it, but they just couldn't really contemplate taking part at this time. Next slide. And so this is quite in contrast to participants under this theme. So some participants told us quite strongly, really, that remote monitoring would serve as a constant reminder of their illness. And this led to a really quite deliberate decision not to take part. So the participant in this quote, elsewhere in the interview, they talked about how they like to go out to walk a lot, they like to go to the theatre, and just generally keep up activities in spite of their illness. So they told me, I try to put it to the back of my mind and just get on with life. That's how I cope with it. It doesn't really stop me doing anything I want to do. I might have to do things a little bit differently, but my mindset is I can cope with it, I can do it. So writing it down every day on an app just didn't appeal to me at all. And this view was in a sort of smaller number of interviews, but where it was present in interviews, it was really clearly articulated and felt quite strongly by participants. It suggests that for some patients, answering questions about illness activity daily is kind of feels like dwelling on the negatives. And for these participants who kind of shared this view, even when we explored, if the evidence base for remote monitoring grew, if your disease was not so well controlled in future, and would you consider it then? Most of them still kind of maintain no, they just find a way around it. They still wouldn't want to try remote monitoring. Next slide, please. So across a majority of interviews, there was evidence that patients had quite quickly formed perceptions of what remora entailed, and this posed a barrier. In some cases, these kind of perceptions weren't necessarily super considered. They weren't necessarily based on kind of reading and digesting the information, but they heard kind of aspects of it, and that led them to be kind of switched off from it. So this participant at the top said, I thought I'd have to put a lot of time into downloading the app and getting set up, and because of work pressures, that freaked me out a little bit. And this idea about perception of sort of time cost and the perceived effort around it was often prominent in patients who perhaps were less likely to face barriers around digital skills, but were still working and really wanted to prioritize work, and maybe that their illness did impact their work, but it was really important for them to continue that. And this view around the kind of time cost and effort was often coupled with another sub-theme. So this idea that some participants had a kind of limited understanding of how remora might change their own care. So the patient in quote, the second quote, when I asked them, what would the benefits of remote monitoring be? They said the benefits of symptom tracking, remote monitoring would be more so for research and to get opinions from people that have the disease. So here and in other interviews, it was framed more so at the population level, the motivations for taking part were kind of altruistic rather than potential improvements to their own care. And I suppose these two things, you know, the perceived effort and then a lack of understanding about the personal benefit kind of served as a bit of a push and pull, I suppose, for why they ultimately decided not to take part or not register. And then finally, for quite a lot of older participants, when they heard that remote monitoring involved an app or a kind of online aspect, they had an immediate reaction to the decline without kind of further contemplation of what it might involve. So this gentleman, who's in his late 70s, he talked quite frequently throughout the interview about kind of avoiding technology. He said to me when I asked him about, you know, what he remembered about being approached, he said, "Oh, there was a guy came to me with a form and asked me, did I want to do stuff online and all this?" And I said no. And actually, I'll talk about digital confidence in more detail on the next slide, but where digital confidence was an issue, prefacing the kind of wider difficulties with digital skills was this sort of immediate response to decline taking part in a trial. People perhaps didn't see app-based interventions as being for sort of people like them. Next slide, please. Okay, so the final theme relates to this idea of kind of digital confidence and skills and its relationship to people's social networks. So a lack of confidence and skill was a very common reason for non-engagement, particularly in older participants. Sometimes this was exacerbated by rheumatoid arthritis symptoms. So, for example, the impact on hands. People talked about brain fog. A couple of people talked about the impact on their sight. It was also compounded for a couple of participants where English wasn't their first language, and some other participants where they might be carers for spouses who also had long-term conditions, who also who had limited digital skills. These participants were dependent on family and friends to support being set up with technology and troubleshoot when something went wrong. So this quote here, number 2, the one in the middle of the page, they said, normally, just to preface it, she was describing when she'd pressed the wrong button on a remote control, changed the aspect ratio, and it kind of distorted a television screen. So she said, normally when this happens, I've rung my son up, I have to wait till he comes home from work, told him what I've done, and he'll go through the control with me to get my telly back. And so this kind of reflects that social networks didn't always kind of reflect the level of need. So family members might live far away, adult children might have their own families, might work. So the kind of the timing that support was needed often didn't match the level of need. Often the kind of limited level of skill meant that support required to learn to use new technologies rather than just kind of troubleshoot an issue quickly needed to be sort of provided in person, where support really generally was maybe only provided available over the phone, or might be kind of when there was infrequent visits from family visiting from kind of different cities, that kind of thing. For, again, a small number of participants, but quite a kind of strongly, clearly articulated view, relying on support to engage with digital health services could also be experienced as disempowering. So this quote was from an individual. I asked her, whether her daughter could have helped to use remote monitoring. And she told me, she doesn't know how I feel or what I want to say. I am the patient at the end of the day. And this was something she kind of felt really strongly about. And interestingly, sort of throughout the relationship, she described having a really close relationship to her daughter. In contrast to some other participants, her daughter lived close by, she visited frequently. But this participant also talks about really valuing a relationship with clinicians and other staff in the hospital. She took quite an active role in communicating with healthcare staff. She talked, for example, about when she got a text to say there was an update on her online portal, she'd just ring up the staff and just get them to explain it rather than kind of bother with online stuff. And she was worried that this relying on her daughter to interface with digital health services might impact on these relationships and how much of an active role she could take in her own care. So social networks are important, but not really a kind of straightforward solution in terms of harnessing that support. Okay, next slide, please. Moving on to the discussion. So I'll just really quickly kind of highlight some points for discussion and summary to hopefully kind of open up some questions. I think one thing we're we're mindful of and kind of considering as we continue to kind of develop our findings is what are the difference between a research setting and a usual care setting for remote monitoring? How might the barriers be the same or different? I think one thing for me is that whether it's in a research setting or being kind of newly implemented in a usual care setting, is remote monitoring is going to be novel. It's going to be novel to clinicians, to patients, and also support staff in hospitals. And I think a lot of these barriers do emerge from its kind of novelty as something new that people don't have much awareness and understanding of. Hopefully we've kind of made a good argument for the importance of recognizing illness experience as being tied to the barriers that people experience for remote monitoring, and also health services, digital health services more widely. Timing comes through as a really clear theme. So it seems that an open-ended offer might better suit some patients with fluctuating long-term conditions than this kind of one-time offer, and that is something that is linked to it being a research setting. There's obviously implications for service design for remote monitoring in future. So, there is some consensus around in future digital health services to have a requirement for an analog option for some patients, but there's perhaps ambiguity in practice around what this looks like. Where do you kind of draw the line? Who can access this? Who do you want to kind of give a shove into using digital health services, and who, do you really kind of recognize are going to lose out if they're not provided an analog option? And finally, this kind of debate around remote monitoring and multimorbidity, this issue. So what comes across from these interviews is that some patients perceive there to be a level of burden associated with remote monitoring. I suppose it raises the question of whether is this compounded for people with multimorbidities who might be invited to engage in multiple remote monitoring pathways focused on single conditions, and that's something yet to be resolved, I suppose. Next slide, please, Caroline. And just quickly, acknowledgements. So Remora is comprised of a kind of large and fantastic team. These themes have been developed kind of through presentation and discussion with the wider team at a number of points. And also just to recognise the input, as Karen outlined earlier, of our PPIE group members, but just to sort of name them, who have been involved for a very long time, much longer than I have in the project, and had a real important input as well. And thank you to all the sort of patients who've been involved as well in participating in the trial. Thanks, guys.
Great. Thanks, everyone. So I think now we can open up for discussion and questions would be great. So I'll stop sharing.
Perfect, thanks.
Great.
Yeah. So we're in a webinar setting, so you can't just open your mic. So please either raise your hand or put something in the chat and I can give you permission. Just telling before we entered, and some of you might have been there, that we had a Zoom accident at some point, so that's why we're using the webinar version. So while we wait for people to come up with some questions, so first of all, so I'm obviously involved in the Remora project, and I'm listening to you guys, and I'm still very excited about what you found. I think it's really, really fascinating and will help us think about more inclusive solutions going forward. I think one of the questions I wondered about, and sort of combines what Karen was speaking about and what you found in your study, Josh. So obviously you spoke to people who either decided not to take part or tried to take part and then didn't manage to, or decided later not to. We'll also be talking to patients who did start monitoring, so they accepted the invitation and then tracked their symptoms as part of the trial, and we can talk to them about what motivated them to do it. We can ask them whether they had any barriers that they managed to overcome, and I wondered whether you think, Karen and Josh, whether there might be some crossover learning between the Remora users and the people who didn't want or were able to use it. Do you think there's value in comparing those two groups?
Shall I? I'll go and then Karen can add to it. Yeah, I think I suppose in our set of interviews we've kind of explored what didn't go right. I suppose what the barriers that couldn't be surmounted were. I think in the sets of interviews also being done in the trial of people who have taken part, hopefully we'll capture people who might have struggled, might have faced barriers, but did have the support to take part and register. So yeah, sort of definitely crossover there. And I also think there's an issue a little bit around viewing registering as a kind of binary. You know, people might register but not really engage much after that point, and that's something that I think we'll continue to explore in the wider trial, because people might still experience digital health inequalities even if they register. They might not use it. So that's something to further piece up.
I might ask, I think Susie's on the call, so I might ask her in a minute to see if she has anything to share from her interview so far. Karen, anything to add?
I mean, you have to acknowledge that every patient is different, they have different needs. But I know from Josh's interviews, I wonder about the support at the beginning of the project as well, because I know 2 of Josh's participants subsequently joined the trial.
Yeah.
Is that right? Yes. So I think the support at the beginning and for the patient is important as well.
Yeah.
Perhaps that needs a bit more.
Yeah, because just thinking about the co-designed support materials that you and the PPIE group have developed, is there anything that you now that we've learned from Josh's interviews that you think, oh, maybe if we were to do this again, or we're doing not another trial, but let's say we do a Remora 3 in some shape or form, is there anything that you feel based on Josh's findings that would be good to add to those materials?
We've produced materials with videos, and we've produced written materials. I mean, I wonder whether the sitting with Nelly might help, you know, when you sit beside a patient and give face-to-face support. I don't know whether it would be feasible, but that sort of thing, that's the only thing I could suggest.
Yeah, so more in-person support or personal one-on-one,
Maybe just add to that, because Karen touched on that. 3 participants who I interviewed did subsequently go on to the register. And I think it comes a bit from this kind of people valuing relationships, valuing feeling there's a person at the end of the phone they can speak to and kind of build rapport with, which is obviously, it sounds a bit fuzzy, but I think if, you know, measures that are able to kind of, you know, create those kind of warm feelings, that's what people value and kind of might push people over the line to register.
Yeah, and it's not good news in a very resource constrained health service, but it's something that comes out from other studies very strongly. So yeah, I think let's have a think about how we can do that sustainably. I think it's probably Dorothy who raised her hand, so I'm going to allow you to talk, Dorothy. There you go. So you can open your mic now and ask your question.
Can you hear me now?
We can.
Just a couple of questions. Not necessarily all they are to do with this. First of all, is there anything that could actually exclude people from taking part in this particular research, apart from the fact that they haven't got rheumatoid arthritis? Is there anything in particular that you're not looking for?
Do you mean in terms of the criteria for joining the trial?
Yes.
Yeah, well, I think one of the obvious things that we spend a lot of time thinking about, and we did some interviews like Josh mentioned at the beginning, where we spoke to people who didn't have English as their first language. And one of the criteria is that people are either able to understand English themselves or have somebody that supports them with that. And I guess that's an important, you know, thing that might exclude people who struggle to read English and to have an interview in English and to use an app in English. So I think that would definitely be one of them that springs to my mind. I don't know if the team thinks.
So basically just possibly the language barrier.
Yeah.
Exactly. The next question is, you were talking about you might be going away from it a bit. This where have the inquiries gone? When you put the thing on the paper to say that if somebody wanted to speak to, pardon me, another patient, where have the inquiries gone, and how many have you had? Is this
Caroline? Yeah, Caroline. Do you know Caroline or Karen? Do you know? Or else we can ask Deb, who's also on the call.
Yes, well, Deb might have some accurate info on this. I don't know if you have, Karen. I don't, but I know that there wasn't very many uh, queries for the support from the peer support group, which came up a fair bit in discussion, didn't it? We thought, we anticipated that there might be quite a call on that support, but in practice there wasn't really. Karen, don't know if you want to add to that.
No, I seem to remember there was one initial inquiry, but and it was offered, but it wasn't followed through. But I might be wrong about that. So, you know, you could surmise that patients don't want peer-to-peer support. It is offered again in the patient newsletter. It's reminded, or they want to talk to a researcher. I don't know how many have actually used the patient advice line. Is Deb on the?
Yeah, I'll ask her to come in to see if she's got
Yeah.
anything at hand. So we're putting you a bit on the spot here, Deb, sorry.
No, it's fine. So we had no direct inquiries from patients specifically asking to speak to a PPIE member. But Karen's right, we did offer it to one patient who was struggling slightly, but that patient then didn't take it up.
I mean, it raises an interesting issue, doesn't it? I think alongside some of what Josh presented about the considered value of social networks, social support, but that was where people were referring to examples within their family or familiar networks. So this idea of potentially substituting that or an alternative where people don't have that support, you know, it seemed to be certainly an important thing to pilot or test out. And but yes, some takeaways from that, you know, in that people didn't come forward to take that up. And you know, perhaps that's something to do with, you know, they're still having to reach out to a stranger, albeit a patient with experience. It's still someone unfamiliar, someone not necessarily hands-on in their network to give that technical support.
Yeah, Lamise, I'm going to ask you just because your question is related to this. So you say maybe it's just having it tell people to give it a go?
Yeah, thanks. You've totally just answered my question. But I've noticed this in a few digital health projects. People often, I don't know, it'd be interesting to see what people think. I think it might be that people sometimes feel comforted that there's actually a human somewhere. And even if they don't actually use it in practice, it's a low cost sometimes measure to say that it's available, even if they don't use it. But it might be something that's comforting, that people find reassuring, that if I wanted to access that, it's there, and they might improve the acceptability of the intervention. So I'm not saying I still think there could be some use for it, but it might be more of a psychology thing. This isn't just, I'm not just talking to, it is not just a faceless digital intervention, that there's someone behind this.
Yeah.
No, just a completely unfounded hypothesis there.
No, but I think that may well be right, Lamise. As you say, it's just adding something that, you know, potentially people can draw on, and, you know, that they're not on their own necessarily if they wanted to reach out and have that support. Thank
Kate, you had a question.
Yeah, thank you. So on that, I just wondered, is the peer support to help people engage with the research, or is it peer support to help manage the rheumatoid arthritis?
Well, the role is not to give medical advice at all.
Yeah,
but,
no.
It was fairly flexible in that if they just wanted to talk to another patient, if they had difficulty in downloading the app or something like that, you know, you could either talk to them or refer them to the right person. It was if they didn't want to talk to a researcher and they just wanted to talk to another patient. So, but it definitely wasn't. But it's interesting because if you go onto Facebook, there are hundreds of rheumatoid arthritis groups, and they all offer advice to each other. And all is pretty useful.
I wonder if it's peer support in the research setting that's different. I don't know. But yeah, like Lamise says, it is comforting for people to know that other people experience similar things. So just having it there, even if it's not used, can
Exactly. It's there if somebody does want it one day.
Yeah. And then I did put a question in the Q&A just about, and I think you discussed it earlier as well, just for a bit more information about the role of that person at the beginning who helped people decide whether they wanted to engage in the research, and who they were, and how, you know, how long they spent, that kind of thing.
Yeah, I mean, that's an interesting one. As a patient, I was approached by a research nurse asking whether I'd like to take part in the project. And it wasn't a really motivating experience, let's put it that way. So I think it's so important.
Yeah,
get it right at the beginning. But they, you know, the research nurses have lots of research projects that they're recruiting to, and they don't, I suppose they don't feel the passion.
Yeah.
Yeah.
Does that answer your question, Kate?
Yeah, and did you mention there was additional help, or was it the peer support for people?
I think that was referring to the peer support.
Right, okay.
So the peer support was the separate offer of support via the helpline, but in terms of the actual startup of, you know, offering the opportunity to be part of the research, that was done by the research nurses, as in the example Karen gave there. So they were just, you know, conveying the initial information about the trial, the opportunity to take part, and then that was followed up then subsequently via phone calls, etc. But then there were different steps in this. I mean, Josh might mention this, you know, if in some of the work that he did, for example, where people may be reluctant at first, but then with some discussion, then we're willing to give it a try.
Yeah, and that's it, isn't it? Having that whole conversation could help someone overcome the barriers if you've got the time to do it. Yeah, thank you.
Yes, thanks.
Good, Golda. I'm going to give you permission now. There you go. Now you should be able to open your mic. It's all very, yeah, I think I hear you.
Can you hear me?
Yes, we can.
And you can see my face as the lioness.
Yes,
we can.
That's definitely my personality. Well, you know, I've listened to everything you've been saying, and I've noticed well, for me, I notice what's happening. We're having sort of parallel patients. We're having those who went onto it very quickly, enjoy using it, take it to their appointments, and people talk with them about it. And those that don't use it for lots and lots of reasons. And it's not that I'm concerned about, it's the fact that they're not using it. How are we going to accommodate those patients that are not using it? How are we going to accommodate them? How are we going to have two systems running?
It's a good question, Golda. a very good question. I don't know if anybody else wants to respond to that, but I guess my initial thoughts, I mean, you know, obviously, there are these issues that we've been talking about in the presentation about how, you know, raises some questions, implications of this, about how you maximize capacity to be involved. But also there are always going to be people who will not want to be doing this remote monitoring of symptoms. I think that was part of what Josh was illustrating, and so I think, you know, we certainly can't press people into it, but I think some people have their own ways perhaps of, you know, trying to draw together information that they bring to those appointments, and I don't think there's one set answer for this, but, you know, that teasing apart perhaps the people who may be open to the idea and, you know, and introducing more flexibility, more support to enable people to take part, even if that's, you know, taking part at what's the right time for them to be able to do this monitoring, but also just acknowledging that there will be a number of people who will not want to use this particular system to monitor.
Thank you, Caroline. The reason I ask it is because although I'm passionate about it and have been with it now for 10 years, and I really do believe in it, it sounds a contradiction, this, but it's not for me. To focus on aches and pains and goodness knows what is not something I've ever done or ever particularly want to do. I mean, you know, if I broke my leg, the concentration would be on the crutches, which are a damn nuisance. And I don't tend to ever look at my RA, ever. In fact, I'm always surprised when I go for an appointment when they say you're in a flare.
Yeah.
And I go, oh, really? Oh, and those joints have swollen. Really? Oh, right. Okay, if you say so. And this is how it is at the moment. The moment I am in a flare, waiting to go in for rituximab, when they get round to it, that is. But in the meantime, I still go and do very difficult jobs in my house because I have no choice. There's only me. But I concern myself a great deal with those that are not like me, that are not doing it, but not like me. You know, I don't know how we're going to help them. And that's the bit that concerns me, because I've always been very passionate about healthcare through the whole of my career. I think, Golda, what we see more and more, partly because there's so much attention for making the NHS inclusive, in particular when it's about making things digital, is that there's more and more a call, not just from people like us, but also from policymakers, that there needs to be a non-digital alternative, and that we can't force digital onto people, because it's I don't think possible to get everybody onto doing a daily symptom report on their smartphone for whatever reason they have. So hopefully, you know, the trend will continue, and we will be able to help people. I want them to be. I mean, I was in the clinic, not this time, but the previous time, and a nurse came up to me and she said, oh, I wonder if I could interest you, and you know, Remora. And I said, oh, I know all about that. And she just ran away. And I thought, oh, well, okay, so she doesn't like she doesn't want me. But yeah, I want people to have the best care. And I firmly believe that this digital way of doing will be fantastic for when a patient goes to the clinic and someone just clicks a button on the screen and there's the whole graph of everything that has been horrible since the last time I saw you. But I hope they can find some way where there's people like myself that could do it verbally. Yeah, well, we'll keep thinking, Golda. I'm going to ask Uta to ask the last question, if that's okay. Okay, no, sorry, yes. No, don't worry, thank you. Uta, I'm going to, so if you open your mic, we should be able to hear you.
Yeah, can you hear me?
Yes, we can.
Perfect. So my original question was, with the peer support, I mean, could it be that the people who are looking at the newsletter and have the app, that they anticipate that there's going to be a time lag in the support system, and then they just get discouraged because they're thinking, I've got the problem now, I need an answer now, in this world that we live in where we always want instant responses? So is there any way we could, I don't know, have a chat version where somebody has, like the PPI group, have it on their phone and somebody can just answer straight away? Or is there a danger of, I don't know, malicious intent and whatever from people who get hold of the chat group?
Yeah, I mean, it's a good point. So you know, Karen, I don't know if you want to.
Yeah, I mean, I might be wrong. Deb will know, but I think there's an automatic response if you email in to say what the times are for answering. I think that's right.
Yeah, it is.
Yes.
Yeah.
In work hours or something.
Yeah. It's just that if you're looking at the app, you want to enter something in, it's not working, you're not sure how to do it, you want to know straight away, what am I doing wrong?
And if you then get this automated response that says, oh, we're only here between 9 and 5, we'll get back to you. And then somebody gets back to them at a time that probably isn't convenient to them. That's what I'm thinking might also discourage people from using the peer support thing. But also to what Golda was saying before about the people who might not be digitally savvy, I think we need to be more kind of flexible with the way that we're approaching this app. And it's like, I'm all for apps, I'm all for the NHS using the information. But if you're asking me, like Golda, I don't want to dwell on my illness every single day and then answer a ream of questions saying, how do you feel? What pain have you got?
Yeah.
Is there a way we can maybe do something like some people don't like answering questions? Sorry.
I think in a way this research is important in that it has identified some of the reasons why patients don't want to engage.
Yeah, I was thinking, is there using AI or just a voice kind of response as well, where somebody can say, oh, today's been really good, I've felt really fantastic, I've been able to do the washing, been able to go out for a run or whatever, and the app somehow puts that into the system into a way that can then be analysed in the future.
Yeah, I think Will was reading your thoughts, so he in the chat he put voice responses as a second on the no, that's good, great minds, I think. And then obviously a smart watch or some more passive monitoring of people's activity, their sleep, and then use that as a proxy for whether they're doing well or not, I think is one of the things that we can think about. I'm really sorry to stop this discussion because it's really interesting, but we're running out of time. Will, I'm sorry, I think you've already got your answer from Lamise, who had a wonderful idea to do a 4D virtual hologram of us promoting the study to people. Can I thank again Josh, Karen and Caroline for your presentation. It's been wonderful to listen to you, and thank you all for a really engaging Q&A. In the chat, I've put the details for the next seminar, which will be on the 8th of October, where we'll have Victoria come and speak about her equity charter, and invitations will be sent out very soon. Thank you very much and have a good afternoon.
Great. Thank you, everybody.
Thank you.
Bye.
Bye.
Keep the chat up a minute. I haven't read some.